Hi, Jeff. I haven't seen your face in a while. Jeff's coming in from Massachusetts, Dr. Mehta.
Hi.
Am I saying your last name right?
Yes, yes.
Okay, good. Hi, Jeff.
Hi.
Hey Dana, how's it going?
Good. If I haven't responded to some of your stuff, I've been traveling and working with our Bay
Oh
Area
yeah.
team, but I know you've been really busy. Jeff
Yep.
is a self-advocate, Dr. Mehta, for autism. He's all over doing all kinds of work for being an advocate for himself and for everyone in the neurodiverse spectrum.
That's
Hi,
awesome.
Benny. I don't know if I met you before. Nice to see you.
This is actually my son's name, Benny. Hi, my name is
Hi.
Madi. Yes,
What's your name?
Medina.
Medina.
Dina. Okay. So you have a son with autism?
Yes,
Okay. And how old's Benny?
he is going to be 8 soon in May, end of May.
Okay. And where are you guys located?
Uh, we live in Forest Ranch, San Diego.
Oh, okay. Great. Well, Dr. Mehta's coming in from El Paso, Texas, and Jeff's coming in from Massachusetts, and I'm in my office in Point Loma and San Diego, and Rebecca's in La Jolla at our main headquarter office where we do all our operations out of. Maybe since it's small right now, we can do it a little bit differently. Do you want to do that, you guys?
Sure.
Sure, why not?
Yeah, because Dr. Mehta was wanting to keep it a little bit more personal anyway. So maybe we could start with you. Sorry, I'm calling you Benny's mom. Is that okay? Because I can see that on the screen. How do you
Yes,
spell your first name? Then maybe I'll remember better.
yeah, so it's Madina. It's Medina.
Medina. Okay. Medina, what do you possibly hope to get out of the Lunch and Learn today? Knowing that Dr. Mehta is a child psychologist, right? Dr. Mehta?
Psychiatrist, yes.
Yes, psychiatrist. And she just is really wanting to share the role with families. And I'm just wondering if you have any thoughts on what you'd like to possibly get out of the Lunch and Learn today, what you'd like to learn.
Yeah, so basically, recently I got a baby, so I'm just curious how my son feels like having 6 months old because he's not really expressing himself a lot, but seems like he is happy. And we don't have this year ESY, so I'm not sure like how his feelings going to be like. Because he has a lot of attention. We have a lot of attention on the baby, and yeah, I just wanted to know and hear some, feedback maybe about that, or yeah, this is my actually first time participating in this group, and just wanted to try to see how it is.
Oh, you know what? It might just be meant to be Medina because normally we do a whole introduction and a recap from all of our stats for the year and what's coming up. But maybe it's meant to be that we have this more personal opportunity to talk today because that's a lot, Dr. Mehta, right? With Medina having a new baby and then her son with autism being 8 and trying to process that. Is that something we could weave into your, we always do a question and answer, Medina, at the end, Dr. Mehta, so we could wait and have it till the end, but I just thought to kick things off, if you guys had any thoughts, you could tell her.
If you don't mind me asking, how old is your son?
My
Benny?
my oldest Benny is right now 7 and almost 8, so he's 7 and he will be 8 on May 29.
Oh, okay. And what about, so almost birthdays here, and what about how is he doing with the school?
He's doing good. So he has, I would say maybe 70%. He has a class with ASD structure, and the rest with general ed. So before, he was kind of okay, but we got some kind of different behaviors when my son just got born. So we would have some aggressive behaviors towards like his peers or because of denied access in school. But recently I just had IEP meeting and they told me like he's doing better because now he has one staff member going with him on lunch and breaks and recess. So I guess that's very helpful now because they trying to explain to him more in details like rules and what to expect. But before he was like mostly on his own.
Mhm.
And,
And so to answer to circle back to your question, how is he feeling?
mhm.
How will he communicate if he is feeling good? How does he communicate?
Just raising his voice, like kind of talk loudly, and just being happy.
And has he done that?
Asking, yeah, and asking more like a personal touches, like I want a hug and can you sleep with me? Like something like a little more extra asking from me than before. So I do that more often now. I spend more time with him, like one-on-one, or like we do like me time. So we just like clap. That's called me time. Yes.
And so it seems like you're already helping him be better with the new addition in your family.
Yes.
Right. So the best person, in my opinion, that can answer the question, how are you doing, or how are they going to adjust to any new stressors, is when you ask the child. And they have different ways of communicating, whether it is by behaviors or by telling you. It just depends. But most of the kids, they do have that adjustment with sibling. It's not just with autism, right? It's just how they communicate and how we give them an opportunity to communicate. That kind of varies.
Yeah, I'm realizing, Jeff and Jesse, hi, I see you on here, that it's a small group, so I was letting Medina say what she wanted to get out of listening and learning today from Dr. Mehta, but I think what might be important, first, we'll save that to the end, Jeff and Jesse, is to let Dr. Mehta kind of share about herself, and just so we can learn a little bit about who you are and what you do in your practice, Dr. Mehta, and then anything else you want. The floor is yours. I'm just grateful for you to be here today. And then at the end, if we have any more people come on at the end, we might do our announcements or our stuff that we normally do in the beginning. Does that sound okay with everybody?
Of course, absolutely, Dana. I'm
Okay.
flexible.
Well, I'm going to give the floor to you, Dr. Mehta.
Thank you. So I'm a child psychiatrist. I have been working with children since 2011. And before that, in my training, I work in a private clinic. I worked in university in El Paso, Texas Tech. And then for 5 years, I was, and then from then on, I started working at a specialty clinic in Providence Children's Hospital in El Paso. And a lot of our focus is on neurodevelopmental disorders, autism spectrum disorder. As a child psychiatrist, we always are part of a big team. Because El Paso is such an underserved area, we don't have an opportunity to create that big team consistently for all the kids. So we work with multiple providers to try and create that team for each and every kid who comes to us. And the focus is a lot on how to help kids be who they want to be, with minimal help from all the team members, or with most we can do. And that's kind of what we try to do, whether it is in school setting, whether it is in home setting, things like that. So it starts with the evaluations and making a formal diagnosis. It starts with good developmental screening and getting therapies in place for the kids and schools, families, so that we can all work together. Once that is in place, the focus changes to they come to us only when there are interventions needed. And when I say interventions needed, as in symptoms that need to be addressed in any of the following settings. So whether it is school setting, whether it is home setting. So a lot of focus of psychiatry and child psychiatry, where we are talking about pharmacological interventions, are based on symptoms rather than treating the disorder. And I think that is something that we try to remember, so that we are not trying to treat each and every symptom, but rather try to look at the big picture and try to help in that way. Okay, and so a lot of focus then becomes on teaching parents how to ask questions and what is it that you can expect from different services, different medications, different symptoms. Most of the times we end up using medications for different symptoms. And so if there are sleep problems, if there are behavioral problems, if there are anxiety problems, if there are depression problems, these are all symptoms with different disorders. Now, so that's kind of where the role of psychiatry or child psychiatry comes in. Okay. Like I said, I kept this as a very informal setting because I was kind of not sure exactly what you guys wanted this as a focus, but a lot of, if you want, I can go into a lot of details about any of these symptoms, but that's kind of where the role that a child psychiatrist plays.
Do you think you can share, maybe Dr. Mehta, what you see most commonly on how you interact and help children, families that have a child or with autism?
What I see most commonly, so a lot of it depends on the age of the child, right? The younger the children, we see a lot more developmental delays. The younger the child, we see a lot more behavioral disturbance. So when I say behavioral disturbance, either the speech is not enough for them to express themselves, so they express by having tantrums, or they express by having more difficulties with self-regulation. As they go into the school setting, the symptoms change. And if you notice, I'm not using diagnoses. If you want to know the diagnoses, then that also varies by the age, right? But a lot of this is more symptom-based, because our brains grow, children grow. So depending upon the age of the child, depending upon what we are trying to do, the symptoms change and the presentation changes. As we go into school, that's when the ADHD symptoms or the hyperactivity, inattentive symptoms, they get more pronounced. Anxiety becomes more pronounced. That's when a lot of times the interventions are focused on that. As we go into the teenage years and the puberty changes, that's when the mood symptoms start coming in more commonly. that does not mean any of the other symptoms are not there. It just becomes more pronounced at that time, because with the puberty changes, hormonal changes, that's when there are a lot more kids with change in moods, more emotional outbursts. That's when a lot more self-harm, suicidality, those symptoms start coming in. And then as we go towards more transition to the college, again, the anxiety spectrum becomes much more common, because now there is a lot more focus on the future, what we are going to do next, transitions, big changes, things like that. So that is usually the spectrum of ages that we see. And as we get into the adulthood, then it becomes their own challenges.
Mhm.
So,
Rebecca, do you have any questions for Dr. Mehta, just to kind of think about what the families
Yeah.
benefit?
Yeah. So, Dr. Mehta, what is it common for some of, so Autism Tree has taken in over 300 new families
mhm,
already this year. And what we found is that a lot of our new families have multiple kids with diagnoses.
mhm.
And those children might have multiple diagnoses. Is
Mhm.
that something that you've seen also recently through your practice?
So yes, so if you look at the workup that goes into the diagnosis for neurodevelopmental disorders, I'm not just going to say autism spectrum or one or the other. If you look at all the neurodevelopmental disorder spectrum, well, the workup that goes into that, it also includes genetic testing, right? And the big, and that kind of is one of the big reasons why it is there, is because there is a genetic burden that kind of can be in the family. So that's why a lot of times parents decide to go through the genetic counseling after the first child, or they decide to get more different opinions, things like that. Thankfully, not everybody has the same risk, but that is still something of a workup that we do, so that we have a better idea about how that will translate into siblings and other kids, right? We don't have a complete genetic ideas and exact genes, but that's kind of the work in progress right now. That's what they're working towards. So yes, is it common to have that in my practice? Yes, it is common. And there is also research into the neurodevelopmental disorders, which in that particular spectrum, there are multiple symptoms that kind of go hand in hand. So before DSM-4 changed to DSM-5, if you had autism, then ADHD symptoms were part of autism spectrum disorder, right? And so you did not diagnose ADHD separately from autism, or at that time it was autistic disorder. It changed to autism spectrum disorder when we went into DSM-5, and that's when they kind of gave the idea that for every diagnosis, you can code it. Why does that matter? That's the reason why now you see multiple children who have multiple diagnoses, because now they are all coded differently, so that for each, and a lot of these diagnoses for that particular symptom is when the medication comes in. So we don't use medicine for treating autism spectrum disorder, we use for the symptoms of autism spectrum disorder that are disrupting the child or family's life.
Thank you for answering that. What are the most common symptoms that you treat?
So the most common symptoms that I end up treating are the first, when they are very, very young, the most of the times, the biggest reason why they have concerns is the sleep disorder. Believe it or not, sleep has been one of the biggest reasons why a lot of parents need interventions, whether it is just sleep training, CBTI, whether it is just helping. There are a lot more other reasons, but sleep is one. Attention deficit, hyperactivity, these are the other common symptoms that we end up treating a lot. Anxiety, right? Self-harm behaviors, not just cutting or anything, but also self-harm behaviors in terms of hitting themselves, banging themselves, scratching, things like that. So a lot of those self-harm behaviors kind of also go into that spectrum. Or tantrums, so lots of aggression. So those are some of them. And I'm just using a generic word, aggression. They come in a lot of different ways. It can be verbal, it can be using inappropriate words, it can be hitting them aggressive towards themselves. It can be using inappropriate, so there's a lot of different varieties of that, but that's kind of what we end up seeing, or those are some of the common reasons why we end up seeing children and then kind of investigating why that is happening in their surrounding.
Are there any steps that you would recommend our families to take before reaching out to a child psychologist or psychiatrist?
So I think the biggest focus, especially if there are, if they already are established, the biggest focus should be in the behavioral interventions. So establish and prioritize the target of therapy. And if it is happening, then, really focus on what is causing some of these problems. So a lot of learning, or a lot of these things can be when you start identifying some of these behaviors, kind of just reassessing what changed or what is the environment, or kind of looking for triggers and kind of reestablishing your goals in therapy to help with that. So Medina here had a very good question, new baby in the house, how the changes, transitions, what is it that is going to affect, or how is that going to affect everyone in the life. So that's kind of a very good example, even before things get out of control, she's thinking about it and trying to figure out how to help the child, right? And so that's kind of what we are just talking about. That's what I would suggest we work on.
Really great to know. And I like hearing that you have you try to set them up with a team. And so tell us more about the team that you work with.
It would be great if I could name everyone, but unfortunately for each kids, we don't have a big team individually, but what we try to establish in the team is first and foremost, the patient, and helping them advocate for themselves, and depending upon what is their vocabulary or how they can communicate, right? Second, family members, right? Parents and other family members. In El Paso, it's very, very common that we have a lot of joint families. So grandmother, grandfather, they are the caregivers for the child. They are, watching them. They are the ones who are doing a lot of childcare, aftercare, things like that. So, empowering them, teaching them, and not just the parent who's bringing for appointment, but everybody who's like part of that caregiving team, siblings, older, younger, because teaching them about a child who cannot advocate for themselves, teaching their siblings how to help their sibling is very, very important and gives a great result. Then school team. So, as part of school team, teachers, teachers' aides, if they are working with a one-on-one staff, coaches. We've had some great results from coaches because, the kids are interested in certain sport or they are interested in orchestra or something, but that person becomes like a mentor. Right? So again, a lot of things just depends. Medical providers, occupational therapist, ABA therapist, physical therapist, speech therapist, anyone who's working in vocational training, anybody who is helping them with any other case management services, other community agencies. I think everyone who has any part to play with that child, they can become a part of the team and help the child develop like a strong sense of support.
Mm-hmm.
So
Totally agree. That's what we try to do at Autism Tree, right? Create that community.
yes, and I think that's one of the big reasons why I like your lectures and everything. It's not just focused on the treatment, but also on building the community.
Mhm. I love
Thank you for that. Yeah.
Yes, because I've seen
Really.
your other lectures and how you are trying to bring in other community members and, really helping with with coming up with different ways of mentoring or helping get a better perspective.
Mhm.
Yeah. Go
Oh, go
ahead, Rebecca.
Sorry.
I was gonna say, thank you for that because we work, really hard on doing the 20 programs that we provide at no charge. And that's why we have over 200 programs on the calendar is to really get the families out because I'm sure you probably see like we do that families with autism isolate themselves. And that's the worst thing that we can do for individuals with autism is let them stay at home. Really everyone should be out every day in the community. And that's why we do over 200 events here. And there's a Padre game going on right now. And our families are at it. And last night they were at it. Whatever doors we can open, we always do. We don't even know how we do all that we do, but we do it because we know that that is going to provide opportunities for socialization, which is so key, and socialization that's not in a clinical environment or in
Sure.
a
I think it
doctor's
is like
office.
crucial. I think there is a comment here like about if the parents have new job search or if they require the new job requires moving or anything, any changes, positive, negative, any changes have a huge impact on children. And not just children with autism. We see a lot of military kids here. So their life is all about moving, right? And as the move happens, and there are some kids who are very, very resilient and they are okay with that life. And there are some children who, for them, they had an established team, they move, and then, now they have to restart from the very beginning and think about going through the whole TRICARE process. And I'm not sure if you have ever dealt with the military insurances and anything like that. It's a huge ordeal to start from the very basics because they make you do sometimes even the diagnosis from the very beginning. So changes, positive or difficult changes, they all have a huge impact on children.
Mhm.
A lot of times they are under parents' control and they can give them a heads up, hey, 3 years, we're going to move. And a lot of times we can't. You know, Apple moved their office to Austin, and now I'm going to be moving to Austin. Like, there is no, you know, I have to move and I have no choice. So, and I'm just giving you an example, but you know, that's kind of how it works. So I think a lot of times we all talk about, you know, we should give everyone a heads up and things like that. And that's exactly what you said. Advance notice has tons of benefits for child. Unfortunately, sometimes we can't do that. And so I always tell every kid who comes to me, especially, I tell them there is one thing which is an ideal setting, and then the other thing which is life. So I want you to have the ideal setting, but be prepared for life,
Mm.
right? Because you are not always have a heads up in life.
Very true. Yes.
That is true. Yeah.
Mhm.
And, you know, I really wish it was not the case, but unfortunately, you know, and because we see so many kids in and out, because we have a huge military base there here. So we start from, okay, this is how we're going to do. And in case this doesn't work, so we try to set up our treatment goal based on what if this doesn't work? How can you deal with it? Or what if option B is not an option? What can you do? So, you know, kind of teaching them different scenarios, right? And again, a lot of things cannot be generalized. A lot of things cannot be done for every single child. I think it's just a format if we can try to get them to at some point, or if we have like a goal, this is what we are going to eventually get to, then you know we can help the children better.
Mhm. It's fabulous. Well, wonderful. I was gonna just pass it off to some of our new families who just joined. Thanks for joining. Andrea has a question, and feel free to type any of your questions in the chat, or you can raise your virtual hand or unmute yourself. It's a nice small environment today, so we really want to have that personal connection with everybody on here. So Andrea says, I've just joined, so apologies if this was already touched on, but how do you address aggressive behavior in an autistic child? How would you begin with that, Dr. Mehta?
Right. So Andrea, that's a very good question, but it's a very difficult question to answer, and I will tell you why. Because the first thing that we have to define is what is aggression, right? And so, like I was saying before, aggression, it's a generic word that we have a lot of different things, right? So like aggression, which is verbal aggression, right? Defiant, using inappropriate words, using hurtful words. That's one form of aggression, to physical aggression. So it's a spectrum, right? Depending upon where we are on the spectrum, right? And depending upon either which words we are using, either what kind of behaviors we are doing, there are different ways we deal with it, okay? We go back to the first thing that we have to do for any child, for any sort of aggression, whether it starts as a verbal aggression, whether they are talking about doing inappropriate or hurtful things, whether they are actually hurting themselves, whether they are actually hurting other people. We start from the very beginning. We start from identifying or trying to identify triggers, right? What happened? When did it start? So first question is, when did it start? And second question is, you know, what happened at that time, to try and determine if something was a trigger, right? Sometimes I just don't feel good. And sometimes it is that, I don't know how to explain that I don't feel good for whatever reason. And that's what causes the aggression. So that's why it's very, very important to start from the very basics, no matter what the behavior is, right? And in ABA, they call it the ABC model, right? And so that's where we start and then try to determine what is going on, right? And then from then on, there are different interventions that go into that. We always try medicine as the last resort, but that's kind of the ultimate thing that it ends up happening. But in between, what triggered or how it happened, or learning those different ways of redirecting is kind of the focus to avoid having to go up to the medication part.
Can I say something in
Sure.
regard to that?
Go for it.
That's always been very confusing to me because my son, he's 4,
Mhm.
and that was the question was about him specifically. His physical aggression towards his siblings or sometimes towards me as well.
Mhm.
It doesn't seem like it's triggered by anything, and
Mhm.
the most confusing thing is that he is usually happy and smiling when he does it. So there's no understanding on his end that's actually that he's causing pain in someone or sometimes even to himself.
Mhm.
So I know that disciplining is completely out of the board, right? There's no
Mhm.
disciplining
Right.
other than just saying no firmly. But it's really difficult for me to address that, especially when it's towards my 2 other kids.
I completely hear you. And so, again, age of the child, right? And what goes into the diagnosis of autism, where there is, difficulties with emotions and social skills, right? And so so it kind of circles back to the same thing, right? That, like you said, there is no awareness of
Yeah.
what is the reaction to the other person, right? Does that mean the behavior is okay or acceptable or excusable? No. But that's kind of the confusion that happens, and especially because of the age of the child, right? And so that's the time when we have to screen them for, is there a comorbidity? So comorbidity as in, is there something else along with autism that can, explain some of these behaviors? And if not, then, ABA is not enough. If that is not working, then unfortunately, you are more heading towards the medication. And again, a lot of it is because of kind of going back to the same thing. The at this age, the disciplining is not going to work. Or at this age, when we don't understand the consequences, what is it that we can do to help the child?
Yeah. Okay. Thank you. Appreciate it.
You're most welcome.
Does anybody else who's joined? Would you're feel free to introduce yourself to Dr. Mehta and ask any questions as well. I do have another question.
Mhm.
So you mentioned some of those families go through genetic counseling.
Mhm.
Explain that process and what that looks like and what that means.
So so it just means that the genetic testing was done. So like, you do after the diagnosis was made of any neurodevelopmental disorder, there are certain genetic tests done to look for genetic syndromes or any kind of chromosomal abnormalities. And after the genetic testing was done, actually, even before the genetic testing was done, we do counseling as to what are the consequences if the results come back positive. And then interpreting those genetic test results, where most likely it's going to be no results. So there is going to be no real answer to why what is happening, or there is kind of a variant of something which is like in between. So we don't know the exact answer. Maybe there is some novel reason why what is happening, or there is a known syndrome that's happening. So those are the things that they discuss in that genetic counseling. So not everybody wants to know what the results are. There are certain genetic tests which we should do for every child with autism, because they put them at higher risk of having certain problems. And so that's kind of what they talk about in the genetic counseling part of it.
What are those genetic tests that that you believe every child with autism should be tested on?
So there are some things which are not there are, so the PCR and the chromosomal microarray or the exome sequencing. These are some of the testings we are always looking for, and Fragile X PCR is what we are definitely looking for kids who also have intellectual disabilities.
It's good just for the parents to know generally what they're called and if they can ask for it.
Sure.
Yeah,
Definitely.
Medina did ask a question in the chat. She said, is it a broad genetic testing? When I was pregnant,
Yes.
the doctor said it can't identify autism.
That's correct. That's why I said they cannot identify autism. They are, once the diagnosis is made, they are more looking into the pathogenesis or the reasons. And because there are a lot of times we don't know the reasons, that's why even before we do that, sometimes you go through the genetic counseling to know if we want to do it or not. Okay. Another question is hesitant to give an autism diagnosis before the age of 2. So a lot of it kind of depends on who you are doing the diagnostic evaluation with. So the ADOS testing, which is called the Autism Diagnostic Observational Schedule, and the ADIR, it's another autism inventory. Okay, autism diagnostic inventory. So these are the two which are approved for kids before 2. So if somebody is certified to do that test, and if you can find that provider to do that test, then yes, you will be able to get the diagnosis even before 2. Unfortunately, a lot of it is because the kids also develop very differently, especially when they go into like a social setting. So that's why a lot of other testings are not approved or used in those settings.
So can you repeat that name of the certification that the doctors have to have?
So the clinicians should be trained in ADOS, or ADI-R. Okay, and these are the tests, like they are called gold standard tests, which are approved by insurance. So if you have these tests done through anyone who is certified, the insurance won't then question the diagnosis or give you a hard time for any kind of services.
So common.
Yes. Yes. So that's why, I said that these are the two things which are these are the two tests which are, now universally accepted, even in school setting. These are that's what they look for.
Mhm. And you're right, Andrea, to echo it. It's a big disservice to everyone involved. If don't get-
Yes.
Early intervention is so important, and especially after the pandemic, there's so many wait lists everywhere that
Mhm.
as soon as possible, getting those services is recommended. Sure.
Mhm.
Welcome to some of our other new families. I love it. People are joining. If you have any questions, please feel free to unmute yourself. Specifically, we're so excited. Dr. Mehta is so knowledgeable about, I feel like this is our first child psychologist that we've had on our Lunch and Learn, or psychiatrist, yeah. So we're really happy that you're here.
Thank you. Thank you. So,
Would anybody love to unmute themselves,
I
introduce?
think Jeff would.
Yeah, Jeff, go ahead.
Yes, Dr. Mehta, I just wanted to comment. I was looking through your CV, and I noticed you went to Drexel
yes.
University. Yes, my sister got her doctorate, got
Oh.
her doctorate there. So,
Nice.
yep, and also I know you serve a lot of military families as well. Both my grandfathers and my step-grandfather have served in the military during World War II. So,
So you kind of identify with a lot of
yes,
that I was
Yep.
telling you about.
yeah, because
It's a very unique situation to be in.
absolutely.
And especially because a lot of the teachings are, just,
No.
you have to deal with what you get
Mhm.
rather than advocate for yourself in that family.
That's right.
Mhm. Thanks, Jeff.
No
I love
problem.
the connections.
Yes.
Andrea did ask, she asked, could you talk a little bit more about sleep regulation and autism? Since it's really common.
Yes, sleep is a big concern. So sleep and eating, these are two big concerns with kids on the spectrum. And a lot of it has to do with if I were to use the word, just the way the brain is wired, and how it impacts, or what is the need that I feel is with the kids. So a lot of times they have, starting from, they are more common to have some GI distress, or they are more common to have other neurological changes. And so that's why their sleep is much more dysregulated. They don't, they have more energy than a lot of other kids. So their sleep changes are very problems. They tend to have insomnia. They have different sleep times, things like that. So sleep problems are very common in neurodevelopmental disorders, which includes intellectual disabilities, autism, any of the developmental spectrum. And if we don't sleep well, that in turn means there is more aggression, irritability, more repetitive behaviors, more anxiety. So a lot of times that kind of becomes one of the big issues we have to work with. Of course, when you start working on that sensory problems that might be disrupting the sleep is one of the first things that we look for. So light, sound, just because everybody sleeps with their lights off, kids on the spectrum, they may have a different way of responding to that. A lot of times weighted blankets or other sensory things that also help with sleep. So again, sensory, and we can go into, it can be like a whole topic, but those are some of the things that we kind of work on when we are looking into sleep disturbances in neurodevelopmental disorders.
Thank you.
For sure, you're most welcome. For the diagnosis of autism evaluation in adults. So it's a little bit complicated because a lot of it has to do with how it is paid for, right? A lot of it has to do with who's going to do the referrals, right? Especially if we are talking about any kind of Medicaid, Medicare kind of insurances. So the best way to start would be start with a psychiatric evaluation, or a psychologist, so PhD psychologist evaluation, because they can be done a lot of times, and a lot of it depends on the insurances and everything. And during that, because the autism diagnosis, even though all these tests are necessary and recommended, it is a clinical diagnosis. So if you read like into details and everything like that, if you can find a good physician, if you can find a good psychiatrist who can do the complete evaluation, it is a clinical diagnosis. So you just have to find a psychiatrist or a psychologist who can work on that. Okay. And
I'll read
if
it
you
out loud just in case because we're recording it, so those people won't know the chat. So I'll just read it out loud. Kelly asked, Dr. Mehta, kids maybe have both autism and ADHD. Will their ADHD get better when they're older, like in their teens, without given any ADHD medicine?
So it's a very it's a very controversial answer I'm going to give you. And so the thing about it is there are a lot of kids who kind of grow out of their hyperactivity portion of ADHD. The inattentive portion, a lot of kids, they just learn to deal with it better. Okay, so the medicine, does it help? Yes, there is a huge literature that supports the ADHD treatment with medicine. Does it cure? No, it does not cure. But a lot of kids, they do better because they learn to deal with it, with the symptoms much better, if that answers your question. Okay. And going back to Jesse, so yes, I think start with going with either the psychiatrist or a psychologist first and see, because even most of the insurances, even if the psychiatrist is not comfortable with that diagnosis, they can make a referral for psychological testing, where the tests where they can do a lot of specific tests for autism, and they are all covered through insurance because you are doing a diagnostic clarification.
To know. We have so many adults that have come up and reached out to us during the pandemic that are getting late diagnoses in their 20s, 30s, 40s, 50s. So it's very common, Jesse. Kelly said, how does cognitive behavioral therapy help our autistic kids? Is it only for kids with anxiety?
So that's a very good question. But what I'm going to tell you is it all depends on the child and what we are trying to achieve, right? And so the cognitive behavioral therapy in in the purest sense. It is good for it is like, you know, so it is a type of therapy in which a person's negative thoughts, so like automatic negative thoughts, I'm not good enough, or this is the worst thing ever. They are examples of automatic negative thoughts. So cognitive behavioral therapy is a type of psychotherapy that is challenging these automatic negative thoughts. We call them ANTs. Okay. And we learn to challenge these thoughts, which kind of cause these troubling emotions. And then we problem solve, right? And then we kind of replace or learn to replace them with more realistic thoughts. So it's a multi-step process, right? And so it's a multi-step process to be effective in the treatment of anxiety with high functioning autism or depression or even disruptive behaviors like aggression, because it also improves like social and communication skills if you are working with a high functioning person, in terms of like if they are able to learn by challenging their thoughts. So to answer your question, is it not just with anxiety? No, but it is much more common with very high functioning kids with anxiety and depression.
Wonderful. Well, we are already at 1 o'clock. That passed by so fast.
Yes.
So
It would
thank
be nice to see everybody's faces. We'll take a group picture with Dr. Mehta and thank her for her time today and generosity with being with us and just being a wealth of knowledge. Like Rebecca said earlier, this is the first time we had a child psychiatrist on at our Lunch and Learn. So it was definitely a blessing, Dr. Mehta. And I know when
So
we
much for
send out,
inviting.
yes, when we send out the recording of this, maybe we can also attach your book that you're a part of.
Thank you.
Do you have that, Rebecca?
Yes, I do have the name.
Okay.
Okay. So I will.
Love seeing your faces. Anybody
Thank
else want to
you.
show your face?
Let's take a picture. I'll just smile at the camera and I'll take a screenshot. Ready? Ready? 3, 2, 1, cheese. Beautiful.
Okay.
Thanks,
Thank you,
everybody.
everybody.
Thank you so much.
Dr. Mehta.
Bye. Bye.
Have a great
Thank you so
day.
much.
Bye. Have a great day. Bye.